Exercise 6.6. Choose one of the given above diseases and write a paragraph providing detailed information. Exercise 6.7. Complete the interview. Think of questions to be asked to receive the given answers. Then role-play this interview in the group. One student will play the role of a specialist and another, a journalist. All other students in the group are the auditory and are supposed to ask some questions to the specialist. The information below can help you. The subject of today's talk is goiter. Now we have got a good chance to talk and discuss this condition with Dr. N, who is a well-known specialist in this area. Dr. N, could you tell us, 1. A goiter is an enlarged thyroid gland. The thyroid gland is a butterfly-shaped organ in the lower front of the neck. It produces thyroid hormones, which are important in regulating the body's use of energy to keep them working properly. 2. Goiters can occur as a result of a deficiency, hypothyroidism, or excess, hyperthyroidism, in thyroid hormone production, as well as the presence of thyroid nodules. 3. Iodine deficiency is one of the most common causes of goiter worldwide. The thyroid gland is responsible for concentrating iodine to make thyroid hormone. With iodine deficiency, the patient becomes hypothyroid and the thyroid becomes enlarged. Hashimoto's thyroiditis is an autoimmune condition wherein there is destruction of the thyroid gland by the body's own immune system. As the gland is destroyed, it is less able to produce adequate amounts of thyroid hormone, eventually resulting to hypothyroidism and goiter. Graves' disease, commonly known as toxic goiter, is another autoimmune disease, wherein the body produces a protein called thyroid-stimulating immunoglobulin, TSI, which stimulates the thyroid to produce excess thyroid hormone, hyperthyroidism, and enlargement of the thyroid. Nodular goiter is the presence of one or more nodules in the thyroid gland which can cause its enlargement. Other less common causes of goiter include genetic defects, injury or infections in the thyroid, and tumors, both cancerous and benign tumors. 4. Anybody can develop a goiter, but they are more common in women than men. It increases in frequency with age, and commonly runs in the family, hereditary. 5. Patients may not feel anything, asymptomatic, or may notice a swelling at the lower front of the neck, or even have difficulty in swallowing, breathing if the goiter is very large. Depending on the underlying cause of the goiter, there may be symptoms of hypothyroidism, fatigue, constipation, irregular menses, muscle pain, weight gain, hair loss, sensitivity to cold, hyperthyroidism, palpitations, weight loss, heat intolerance, tremors, shortness of breath, bulging eyes, sleep disturbances. 6. The treatment will depend upon the underlying cause of the goiter. If it is due to a deficiency of iodine in the diet, you will be given iodine supplementation, which may lead to reduction in the size of the goiter, but often will not completely return to its previous size. If the goiter is due to hypothyroidism, you will be given thyroid hormone, levothyroxine, usually as a lifelong replacement. If the goiter is due to hyperthyroidism, the treatment will depend upon the cause of the hyperthyroidism. In such cases, patients will be given anti-thyroid medication or radioactive iodine therapy. If the cause is multinodular goiter and there is presence of obstructive symptoms such as difficulty in swallowing or breathing, your doctor may suggest surgical removal of the goiter. 7. Goiters that are very large may constrict the airways and may cause difficulty in breathing. If the cause of the goiter is a nodule or nodules, there may be a risk for cancer. 8. If you, or anyone around you, notice any swelling, enlargement, or palpable mass in your neck, it is best to consult an endocrinologist for appropriate tests, accurate diagnosis, and timely management. Other conditions that should prompt you to see an endocrinologist. 1. Presence of goiter with signs and symptoms of hypothyroidism or hyperthyroidism. 2. If you develop goiter while on treatment for hypothyroidism or hyperthyroidism. 3. If you develop goiter during pregnancy. Tirzepatide versus semaglutide once weekly in patients with type 2 diabetes. Tirzepatide is a dual glucose-dependent insulinotropic polypeptide and glucagon-like peptide 1, GLP-1, receptor agonist that is under development for the treatment of type 2 diabetes. The efficacy and safety of once-weekly tirzepatide as compared with semaglutide, a selective GLP-1 receptor agonist, are unknown. Glucagon-like peptide 1, GLP-1, receptor agonists are an effective treatment option for patients with type 2 diabetes. These agents act by stimulating insulin secretion in hyperglycemic states, suppressing glucagon secretion in hyperglycemic or euglycemic states, delaying gastric emptying, decreasing appetite, and reducing body weight. Glucose-dependent insulinotropic polypeptide, the main incretin hormone in healthy persons, is insulinotropic however, unlike GLP-1. It is glucagonotropic in a glucose-dependent manner. Under hyperglycemic conditions, glucose-dependent insulinotropic polypeptide stimulates the release of insulin, thereby lowering glucagon levels. And under euglycemic or hypoglycemic conditions, glucagon levels are increased. Glucose-dependent insulinotropic polypeptide receptors are abundant in adipose tissue. And glucose-dependent insulinotropic polypeptide enhances both the postprandial lipid buffering capacity of white adipose tissue and the sensitivity of adipose tissue to insulin, which may prevent ectopic fat deposition. The glucose-dependent insulinotropic polypeptide component of dual glucose-dependent insulinotropic polypeptide GLP-1 agonism is hypothesized to act centrally to potentiate a GLP-1 induced reduction in food intake. In patients with type 2 diabetes, a single molecule combining the glucose-dependent insulinotropic polypeptide receptor and GLP-1 receptor agonism may have a greater effect on glucose levels and weight control than selective GLP-1 receptor agonists. Tirzepatide is a dual glucose-dependent insulinotropic polypeptide GLP-1 receptor agonist. Its structure is primarily based on the glucose-dependent insulinotropic polypeptide amino acid sequence and includes a C20 fatty diacid moiety. Its half-life of approximately 5 days allows once-weekly subcutaneous administration. A Phase 2b trial involving patients with type 2 diabetes showed that those who received tirzepatide had dose-dependent reductions in the glycated hemoglobin level and weight at 26 weeks. Once-weekly injectable semaglutide, a selective GLP-1 receptor agonist, is approved for the treatment of type 2 diabetes at doses up to 1 mg. In trials involving patients who received semaglutide, the mean reductions in the glycated hemoglobin level have been reported to be as high as 1.8 percentage points, and the mean reductions in body weight have been reported to be as high as 6.5 kg. We conducted the SURPASS-2 trial, a study of tirzepatide versus semaglutide once weekly as add-on therapy to metformin in participants with type 2 diabetes, to compare the efficacy and safety of tirzepatide at doses of 5 mg, 10 mg, and 15 mg with those of semaglutide at a dose of IMG in patients with type 2 diabetes that had been inadequately controlled with metformin monotherapy. Discussion. In the current trial, tirzepatide at a dose of 5 mg, 10 mg, or 15 mg was non-inferior and superior to semaglutide at a dose of 1 mg. With respect to a reduction in the glycated hemoglobin level in patients with type 2 diabetes who were receiving metformin, tirzepatide was also superior to semaglutide with respect to reductions in body weight. A total of 82 to 86% of the patients who received tirzepatide and 79% of those who received semaglutide reached the glycated hemoglobin level target of less than 7.0%, that is recommended by the American Diabetes Association and the European Association for the Study of Diabetes. The glycated hemoglobin level target of less than 5.7%, normoglycemia, was met in 27 to 46% of the patients who received tirzepatide and in 19% of those who received semaglutide. The patients who received tirzepatide at a dose of 15 mg had almost twice the weight loss of those who received semaglutide at a dose of Img. Weight reduction did not plateau in any of the 4 treatment groups at 40 weeks. A glycated hemoglobin level of less than 5.7% without an increased risk of hypoglycemia has not been considered attainable with current treatment options. In our trial, this goal was met with a gastrointestinal-related side effect profile that was similar to that reported with GLP-1 receptor agonists. In addition, many patients who received tirzepatide were noted to have an improved lipid profile as well as improved blood pressure, biomarkers of insulin sensitivity, and liver enzyme levels. We speculate that dual agonism, glucose-dependent insulinotropic polypeptide receptor and GLP-1 receptor, may allow some patients to reach near normal glycemia with potential long-term benefits. Gastrointestinal adverse events reported with tirzepatide and semaglutide were consistent with those that would be expected with the GLP-1 receptor agonist class and were mostly mild to moderate and occurred during the escalation period with both trial drugs. The most common reason for premature discontinuation of tirzepatide or semaglutide was adverse events, which were more common with tirzepatide at a dose of 10 mg and 15 mg than with tirzepatide at a dose of 5 mg and with semaglutide. Although there were numerically more deaths with tirzepatide, COVID-19 was a confounder in 5 of the deaths and presumptively involved in a 6th death. 5 deaths were adjudicated to be related to cardiovascular causes, all in the tirzepatide groups in addition to type 2 diabetes. 3 of those patients had previous risk factors and established cardiovascular disease, and a 4th was a smoker and was overweight. Our trial has several strengths. The reductions in glycated hemoglobin level and body weight observed with semaglutide were consistent with the results already reported in the SUSTAIN, semaglutide unabated, sustainability in treatment of type 2 diabetes clinical trial program. In addition, in the 68-week Step 2, semaglutide treatment effect in people with obesity trial, which assessed semaglutide at doses of Img and 2.4 mg in addition to lifestyle intervention for long-term weight management in patients with type 2 diabetes. The estimated treatment difference in weight loss was minus 2.7 percentage points with semaglutide at a dose of 2.4 mg as compared with semaglutide at a dose of 1 mg and minus 6.2 percentage points with semaglutide at a dose of 2.4 mg as compared with placebo. These results are consistent with those reported in our trial with semaglutide at a dose of Img for weight reduction. Other strengths of our trial include an active comparator, semaglutide at a dose of Img, and a large sample size with a large number of patients who completed the trial. In patients with type 2 diabetes who were receiving metformin, the novel once-weekly dual glucose-dependent insulinotropic polypeptide GLP-1 receptor agonist tirzepatide was non-inferior and superior to the selective GLP-1 receptor agonist semaglutide at a dose of Img, with respect to the mean change in the glycated hemoglobin level from baseline to 40 weeks. Exercise 7.1. Answer the following questions. 1. What is the effect of GLP-1 receptor agonists? 2. What is a specific characteristic of glucose-dependent insulinotropic polypeptide? Where is it present in large amounts? 3. What is the advantage of glucose-dependent insulinotropic polypeptide over selective GLP-1 receptor agonists for the therapy of patients with type 2 diabetes? 4. What findings were obtained in the trial comparing the efficacy and safety of Tirzepatide and Semaglutide in patients with type 2 diabetes? 5. What adverse events were noted with Tirzepatide and Semaglutide? 6. What were the strengths of the discussed trial? Exercise 7.2. Find the following phrases in the text and translate the sentences. Paraphrase these sentences, conveying the author's ideas using different vocabulary and sentence structure. 1. To be consistent, to be mild, to moderate, to be confounder, to be presumably involved, to be adjudicated, to be under development, to be abundant, to be superior to. Established disease lifestyle intervention weight management treatment option acts centrally. Exercise 7.3. Write a summary about the actions of insulin using the ideas below. You are supposed to add linking phrases, modal verbs, and some other words to connect the information logically. Glucose reduces glycogenolysis and gluconeogenesis and increases glycogen synthesis in liver. Increased uptake of glucose and synthesis of glycogen in skeletal muscle. Uptake of glucose and synthesis of lipid in fat tissue. Protein uptake of amino acids and synthesis of protein in skeletal muscle. Decreased protein breakdown in liver. Lipid glucose converted to lipid in fat tissue. Reduced lipolysis in fat tissue. Excessive blood glucose increases the risk of infections. Neuropathy allows damage to go unnoticed and untreated until a major infection develops.